my name is Walter Woznick, and I'm an assistant professor in endocrinology at the Medical College of Wisconsin. Today, we're going to have a discussion on management and evaluation of thyroid nodules. Thyroid nodules are quite common and increase in incidence with age. Women tend to have more palpable nodules than men, with an approximate incidence of 5% in women and 1% in men. High-resolution thyroid ultrasound, if we conducted this on every individual in the population, we would find roughly anywhere from 19 to 68% of individuals having a thyroid nodule. I will typically quote this in the clinic to patients as saying about 50% of all people that have a thyroid will have a nodule in it. Thyroid cancer will typically occur anywhere from 5 to 15% of individuals that do have thyroid nodules. There are various things that will determine the likelihood of having a cancerous nodule. So those might include age, sex, radiation exposure, a family history, iodine deficiency, or other factors, including potentially Agent Orange for veterans that you may see. With any nodule in any gland, we should consider three main things. First thing is, of course, is it cancerous? Second thing, is it a functional nodule that is producing a hormone? The third is this a benign nodule that is eventually growing over time, not cancerous, but might cause some compressive symptoms or other problems if it continues to grow? One question you will get quite commonly in the clinic is, what is a thyroid nodule? So from the prior slide, we know that about 10% of these are actually cancer, but the other 90% are benign or not cancerous, and so it's important to understand what those might be as well. Certainly you can get nodules that are filled with fluid. These would be more cystic. But we think probably the rest of the nodules are coming from inflammation that occurs within the thyroid. Inflammation in the thyroid occurs over time as a product of fighting off infections within the body and fighting off inflammation in other areas of the body. This can carry over to the thyroid and create a density difference that we see on an ultrasound, resulting in a thyroid nodule. One of the most important tools we have to evaluate thyroid nodules is the thyroid ultrasound. A thyroid ultrasound is a very helpful tool to assess and evaluate a nodule, but it does have some limitations. One important thing to keep in mind is that you cannot determine what the composition of a nodule is on an ultrasound alone. You do get important features of a nodule, and you can tell the size of a nodule and measure it very accurately with an ultrasound. But it's important to keep in mind that these features are only suggestive of a potential issue that you might want to evaluate further with fine needle biopsy. Upon initial discovery of a thyroid nodule, you're going to consider two main things. First, is it cancerous? And second, is this a functional nodule? To determine if it's cancer, you'll evaluate the thyroid ultrasound and look at the nodule based on size and characteristics of the nodule. We'll then use guidelines to help us direct if we should pursue a biopsy or not. We'll talk about those guidelines in later slides. Second thing you should always consider is the nodule a functional nodule? Although that's uncommon, you can find that, and the TSH should be measured with each thyroid nodule evaluation. A TSH that is low might suggest an excess of thyroid hormone production. You might consider completing a thyroid uptake and scan study to determine if that nodule is a hot nodule. Hot nodules tend to not be cancerous nodules, and so we typically don't pursue a biopsy of those nodules. If you did happen to biopsy a hot nodule, what it tends to show is just hyperplastic cells that tend to be not cancerous. Upon initial discovery of a nodule and evaluation, of course, you always want to complete a thorough history and physical exam. There are some things that you would consider if a cancerous nodule is present and growing in excess, if it's having mass effect within the neck itself. A couple things that you typically find early on is that patients will have difficulty swallowing, and they'll have vocal cord paralysis or issues with their voice. Of course, not all nodules do that, so it doesn't apply to everyone, but it is something to consider. Other things to consider is if you're going to measure things like calcitonin or not, looking for medullary thyroid cancer. It is something that you might think about in individuals that are on GLP-1 agonists, but it is not a generalized recommendation that every person that's on a GLP-1 agonist would have a calcitonin level measured. You might also consider measuring calcitonin in those individuals that have a higher propensity of medullary thyroid cancer in the family or MEN syndromes. Sometimes you'll be referred for a nodule that was incidentally discovered on a PET scan that had not previously been discovered on a thyroid ultrasound. Nodules that light up or are PET positive do have a higher propensity of being cancerous, somewhere in the neighborhood of around 30 to 35% are actually cancerous, but not all. So it is important to know that this is probably a higher risk factor for cancer in that nodule and is something that you would consider in conjunction with a thyroid ultrasound, size, and features. The ATA, their guidelines would recommend a biopsy of any PET positive nodule that's over 1 centimeter in size if there's focal uptake within the nodule. If there's diffuse uptake within the thyroid gland itself, this is probably more suggestive of thyroiditis. No further imaging or FNA would be required in those cases of thyroiditis. If a thyroid nodule falls in the categories of TIRADS 3, 4, or 5, and we don't pursue a biopsy on that, we would generally continue to follow it in this scenario is listed in the previous slide. So if a TIRADS 5 nodule is greater than half a centimeter, if a TIRADS 4 nodule is greater than or equal to 1 centimeter, or if a TIRADS 3 nodule is greater than or equal to 1.5 centimeters. This gives the outline of when we would typically follow those. TIRADS 5 nodules, it would be once a year for 5 years. TIRADS 4 nodule would be at year 1, 2, 3, not year 4, but then year 5. TIRADS 3 nodule would be every other year, so 1, 3, and 5. So generally, after 5 years, we can typically stop imaging if there's no change in size or characteristics, as stability would tend to imply a benign nodule. But again, ultrasound doesn't prove cancer or not cancer. It would just be more suggestive of the fact that it's benign. This is probably more of a suggestion and should be taken on a case-by-case basis with your patient to determine if you continue to monitor after 5 years. In general, it's probably safe to say that it's unlikely that a nodule would be cancer if it's unchanged over 5 years. If a nodule's TIRADS level increases on follow-up, the next sonograph should be done then in 1 year, regardless of whatever the initial level was. The other major guideline that we use is the American Thyroid Association guideline that is pictured here. This is helpful for early learners as it gives pictorial examples of what each nodule looks like, so it's less of a word description to try to figure out what nodules look like. I put on the right-hand side of this what correlates roughly to the American College of Radiology classifications in terms of nodules. I think the main things that you can pick out of this is that the ATA tends to recommend biopsy at smaller sized nodules and for lower suspicion nodules. So for the very low suspicion nodule, which would roughly correspond to a TIRADS 2 nodule in the ACR, we would actually consider a biopsy in those cases if it's greater than or equal to 2 centimeters. A low suspicion nodule that would roughly correlate to a TIRADS 3 nodule, we would biopsy if it's greater than or equal to 1.5 centimeters. An intermediate suspicion nodule, we would consider biopsy, which is again roughly correlated to a TIRADS 4 nodule if it's greater than or equal to 1 centimeter. And the same for a high suspicion nodule, which would be a TIRADS 5 nodule, which is about the same recommendation from the ACR. Overdiagnosis and overtreatment of thyroid nodules is associated with potentially excessive costs and non-negligible morbidity for patients that we'll talk about in a few slides, particularly as it pertains to obtaining thyroid biopsies. The USPSTF does recommend against screening for thyroid cancer in asymptomatic adults. It's not unreasonable to get an ultrasound though in a patient with a palpable nodule or where an incidental nodule has been discovered from another imaging study. These findings that are consistently associated with malignancy are things like hypoechogenicity, if it's infiltrative, if there are irregular or lobulated borders, if there are intranodular microcalcifications, and if there is a shape of taller than wide in the thyroid nodule. Recent prospective analysis showed that TIRADS system to be superior and reduced the number of biopsies performed with a false negative rate of around 2.2%. It was initially developed to detect papillary thyroid cancers, but has also been reliable in detecting medullary thyroid cancer, follicular cancers, and metastases. The TIRADS system and those sets of guidelines is typically what you'll see on the reports of thyroid ultrasounds from Freighter. Thyroid biopsy results with a whole new set of classifications. This data is far stronger than characteristic data that you get from ultrasound and should be held in higher regard. Once a biopsy has been completed, we know what the cells are inside that nodule. There are 6 different possibilities that you can get from a thyroid biopsy. The first is Bethesda 1, which is considered to be a non-diagnostic where there is inadequate amount of cell material that was obtained. Bethesda 2 is considered to be a benign nodule with a risk of cancer probably in the 0 to 3% range. The 2 atypical forms of results you can get are Bethesda 3 and Bethesda 4, and we'll talk about what to do or options of what to do with those in the next couple of slides. And then the 2 malignant results you get are Bethesda 5 or Bethesda 6. Generally, we refer those for surgery and removal of part or all of the thyroid. Thyroid biopsy results can lead to atypical cells being found on the biopsy. These would be a Bethesda 3 or Bethesda 4 nodule. Bethesda 3 nodules carry a risk of cancer of about 5 to 15%, as you can see in the table below. Bethesda 4 nodules carry a risk of cancer of about 15 to 30%. And then the malignancy diagnoses typically carry a risk of cancer greater than 60%. If you get an atypical nodule, there's a handful of things you can do. Typically or historically, these patients were just sent for surgery, and that's how we had determined what the risk of cancer is in the nodules in the first place. But with such a low risk, most of these patients didn't actually need to have the surgery completed, as there was no cancer in the vast majority of those patients in the first place. Other things you can consider doing, we now have molecular testing that can further characterize the nodule. It's very similar to a thyroid biopsy. It's a single pass. Once completed, it's sent off. PCR is completed to assess for any genes that are typically associated with malignancies of thyroid. If there are genes present, it tends to increase the post-test probability such that the likelihood of cancer in that nodule is much higher, on the order of usually greater than 50%, or getting close to that 60% mark, like if it was a malignant biopsy result in the first place. If there are no genes detected, it tends to lower that risk below 5%, but it tends to not be lower than 1%, which is what we sometimes will find with the risk of cancer with a benign nodule. Molecular testing is helpful. It's another piece of data that can be helpful in determining the next steps with what to do with a thyroid nodule. If those tests are inconclusive from molecular testing, surgery is still usually the best option. If it's a nodule that's large or causing other issues. Oftentimes we will just watch these nodules on ultrasound as well. If it's desired to have the nodule removed or destroyed, but surgery is not desired, there's a few other things we can consider on the next slide. The other options for removing or destroying a thyroid nodule are seen in this slide. The main two things that we use at Freighter are either a percutaneous ethanol injection or a radiofrequency ablation. I will say clinically, though, these are used quite infrequently, even at Freighter. Typically, we'll use some form of either molecular testing, observation, or surgery. Details of these procedures are here below. This slide talks about some of the contraindications of completing a thyroid biopsy. Some of these are more relative contraindications, some are more absolute. Probably the one that comes up most frequently are patients that are on blood thinners. The risk of doing a thyroid biopsy for a patient who's on a blood thinner is a subcutaneous hematoma. One of the more common things that we have to deal with is patients that are on Coumadin. Ideally, we'd like an INR that's under 1.5, the Coumadin to be held for at least 10 days. This is often coordinated with the anticoagulation clinics. They would be bridged to heparin. We can use some other things as well. DOACs are generally recommended to be held for at least 24 hours. Aspirin tends to be less of an issue if it's under 100 milligrams, but should also be held the day of the procedure. Some other things that you would consider is if the patient is just physically unable to complete or uncooperative with the biopsy. You should also consider if there's any risk for things like paragangliomas, carotid body tumors, iconococcal cysts, or highly vascular lesions that might make bleeding more of a risk. This slide talks about the complications from thyroid biopsy and their rates of occurrence after having a thyroid biopsy. So the common things we usually consent patients for is that there's complications of pain, bleeding, infection, and then possibly hitting things or damaging structures nearby the thyroid nodule that we're trying not to hit. So those are the main things that we would typically see, although usually pain is probably the most common thing that we have to deal with in terms of the thyroid biopsy itself. In terms of long-term follow-up for thyroid nodules, if you've already gotten a biopsy, you would still consider getting thyroid ultrasounds to look for any changes in size or characteristics of the nodule. Typically, if you've gotten a biopsy, the likelihood of cancer is extremely low in that nodule. But if you do see a size and change or characteristics, you may consider a second FNA procedure to be done. If you've done two prior biopsies and both are benign, we have this sort of two and done rule that the likelihood of cancer in that nodule is so low that we generally would not do a third.
biopsy on the nodule, even if it's changing. If it is changing, getting bigger, we would usually just send that for surgery. So very low suspicion nodules or spongiform nodules don't necessarily need follow-up, but that would be more between you and the patient. If you do consider follow-up, it's usually after 2 years to see if there's any major changes. And then nodules are generally followed for a period of 5 years. If unchanged, it's considered that those nodules are likely benign and doesn't necessarily require any further follow-up after that. If a nodule is shown to be benign and it continues to grow, there are some things that we can do. So if it's over 4 centimeters and giving the patient compressive symptoms, in other words, difficulty swallowing, breathing, or voice changes, you can send that patient for surgery. Or if it's continuing to grow, you can send that patient for surgery as well to have that thyroid. Usually it's just a lobe removed. There are some other things that come up, like the cystic nodules. Sometimes those can get bigger over time. We do often attempt to drain on those, and they're usually pretty low in the success rate, although sometimes it is successful, so usually less than 40% success rate. If it's not successful to be drained, typically we would recommend to have surgery to be completed and the nodule removed. Sometimes we can also use an ethanol ablation. Takes multiple treatments. We do that here at Freighter, but it's definitely a more rare way to treat cystic nodules. These next two slides go through the major guidelines for managing and following thyroid nodules. So those are in here for your review. I will leave that for you and not go through these in detail. Last couple slides here is just a little case study to look at as one of the patients that I had completed a biopsy on. It's a 42-year-old female with a past medical history of obviously a thyroid nodule, tobacco smoke, history of anemia, large hemorrhagic ovarian cyst that had a right salpingo-oophorectomy. She was referred to me for a thyroid nodule that was discovered on just a routine screening thyroid ultrasound, which again, typically we wouldn't do with USPSTF. But in this case, she had an ultrasound completed. Did show this nodule that was small in the front of the thyroid. So you can take a whack at trying to grade this for yourself. But the ultrasound came back and showed that this was considered a TIRADS 4 nodule, was solid. They considered isoechoic. I would have called this hypoechoic. Not taller than wide. They thought it was lobulated and irregular. I might even go as far as to say that it might have been extrathyroidal, as you can see on the right side of the picture, pushing out of the thyroid just a little bit. And then they called echogenic foci. I thought this was a little more concerning than what it got read as a TIRADS 4, so we went ahead with the biopsy since it was just over a centimeter. Completion of the biopsy of this nodule showed it was a Bethesda 6 cytology, so papillary thyroid cancer that came back at 1.3 centimeters. So the patient was referred for surgery and had that part of the thyroid removed, effectively so far to date curing her papillary thyroid cancer. I hope this lecture was helpful for you. If you do have any other questions or anything you'd like to discuss or want more details about, please feel free to reach out to me. My email is on the next page.